NYU Langone. So the first question I want to ask you, if you can hear me okay, because I'm in the office right now, I'm wearing a mask. And if you have trouble hearing me, let me know. Let's see if I can switch it to a different mask or take it off altogether. It's my pleasure to be here to speak on behalf of Sumaira Foundation, NMO from the Expert Live series. This is programming made possible by a grant from Viela Bio, which is a pharmaceutical company dedicated to the development of commercialization of novel life-changing medicines for patients with a wide range of autoimmune severe inflammatory diseases. The approach to drug discovery is aimed to providing targeted treatments for improving outcome for thousands of patients with few or no therapeutic options. So this is an announcement from the sponsor, and we appreciate their sponsorship of this talk. And we're going to organize it in two parts. The first part, I'm going to talk a bit about NMO. And the second part, we're going to take questions. And I think people enjoy the question and answer series more than the didactic. So I'm going to try to not to go over time with the presentation and to allow people to ask whatever questions they might want to ask. And I'll start out just by way of introduction, just letting you know a little bit about myself and how I got started with NMO. So actually, I remember when it happened pretty well. This was in my residency during my neurology training. I was at the hospital on call at Montefiore Hospital in the Bronx, and we were admitting a patient. I remember her very well. She was blind and she was paraplegic, and she carried a diagnosis of multiple sclerosis, and she was coming for a MS attack. So in those days, we didn't have electronic records. I had to go to medical records to pull her charts because she had multiple admissions in the past, and try to see what the history was. And in one of the notes, I found an interesting comment by one of the senior doctors in our hospital. He said that the patient has diagnosis of MS, but he wonders if she might have de Vick's disease because there is such an involvement of the optic nerve and the spinal cord. And I've never heard about it at this point. It's quite a rare disease. I kind of piqued my interest, started learning about it. And I thought that her case did indeed fit the diagnosis of de Vick's disease very well. And one thing that was kind of a little sad is that she was treated for MS and didn't respond well to treatments. And that was not unusual. That was about 20 years ago. So at that time, when NMO was much less known as it is now. So she was coming in and she had the NMO and she had another very unusual disease called myasthenia. And to have two such rare diseases, it's kind of exceptional, 1 in a million. And the next day I was presenting the case to my attending, and I said, this patient comes in, she might have MS, or maybe she has this NMO, and she also has myasthenia. And my attending, who was a senior doctor at the time, she said, well, it's very interesting because I have a patient with the same name who also have NMO and myasthenia. And I thought you were talking about the same patient, but it wasn't. It was actually a different patient in his practice who had these two rare diseases. And the chances of two of them happening together are extremely remote, maybe 1 in a few million. So I started looking into this, and I found in the literature two similar reports of those two rare diseases, and I wrote to the authors of those reports, and we ended up putting together a series of 4 patients, kind of an interesting and unusual observations. And as I was writing it up, one of my colleagues came up to me and he said, well, I know you're working on this case. Did you hear about the new discovery? And I said, what new discovery? He said, well, they discovered an antibody for NMO. So this is like a big thing. We never had any way to diagnose this disease except by clinical history and examination. And so this, I'm kind of dating myself because this is where the article came out from the Mayo Group. I think it was about 2003, 2004, something like that. It came and described the antibody, and it made a case, a very strong case, that this is maybe an antibody-mediated disease. And the other disease that I mentioned, the myasthenia, is also antibody-mediated disease. So we thought maybe there is a connection between the two, and we ended up publishing this case series. And this kind of a chance encounter, chance occurrence, is what kind of led me to become more and more interested in this disease. And I've been involved with it ever since. And now that I'm at NYU for about 15 years, We even organized a kind of a medical home for NMO and MOGA antibody diseases. We call it NMO Treatment and Research Center, and we try to provide cutting edge treatments to all patients with those rare diseases. So that's just a little anecdote. It's kind of interesting how life takes different directions depending on just one patient encounter, because it usually starts for us with a patient and kind of takes it from there. So let's talk about those diseases. We have, I would like to take maybe 15, 20 minutes to discuss them. And I will then take questions. So both neuromyelitis optica spectrum disordered and MOG antibody-associated disease are relapsing autoimmune diseases of the central nervous system. Relapsing autoimmune disease. So we have a lot to kind of unpack here. We have to define each word and kind of explain what it means. What does it mean to be relapsing, autoimmune, and what is central nervous system? So let's start with the central nervous system. So the nervous system is traditionally divided into two compartments, the central and the peripheral. And they have different compositions. So the central nervous system is composed of the brain, the spinal cord, and the optic nerves. And the nerves in the central nervous system are covered with myelin, which is made by a particular kind of cell called oligodendrocyte. You're going to hear that again, oligodendrocyte. And the nerves in the peripheral nervous system are also covered with myelin, but this is made by a different kind of cell called the Schwann cell. So even though there are nerves here and nerves there, there really are differences between them, between the central myelin and the peripheral myelin, and it ends up being very important in terms of understanding those diseases. And the other structure that we mentioned is optic nerve. It doesn't quite fit. Okay, brain and spinal cord, maybe you can see, I understand why that would be. But what does optic nerve have to do with it? Why is it not a nerve just like any other nerve? So it turns out that the optic nerve is covered also by the central myelin. Myelin made by oligodendrocytes rather than the Schwann cells. And it's encased with a fluid, which we call cerebrospinal fluid, just like the brain and the spinal cord is encased in cerebrospinal fluid. So all those structures, optic nerve, brain, and spinal cord, are enveloped. They live in this fluid called cerebrospinal fluid, and there are some differences in terms of the myelin with which those nerves are covered. So this is the definition of the central nervous system. And what are the implications? In NMO, we're going to call it NMO for short, it's technically known as NMOSD, and MOGA antibody-mediated disease, which we're going to call MOGAD for short. Both NMO and MOGAD, there is involvement only of the central nervous system. So we don't see neuropathies, we don't see radiculopathies, we don't see muscle involvement really in those diseases, because those structures, roots and nerves outside, peripheral nerves and muscles, are not part of the central nervous system. And that might explain, clinically what kind of symptoms we see in these diseases. So that's, okay, so now we got the central nervous system down pat. Let's talk about autoimmune. So what does it mean to be an autoimmune disease? There are a lot of autoimmune diseases out there. There are more than 100 autoimmune diseases that afflict humans. Some of them are very targeted and target just one organ. An example would be something like alopecia areata, which is not an immune disease. Sometimes you see a person has like a bald spot that's attacking the hair follicle. It's a very, very targeted disease, not really dangerous in any way because none of the internal organs are involved. And then there are autoimmune diseases that are much more serious, something like systemic lupus erythematosus, where multiple different organs are involved. And then there are neurologic autoimmune diseases, where the autoimmune attack is directed at the nervous tissue. And NMO and MOGAD are considered neurologic autoimmune diseases. So autoimmune disease, people often think that it means that their immune system is defective. And they often get kind of scared that they might be prone to infection. That's actually not the case at all. In fact, the immune system is a little hyperactive, and it seems to be attacking, body's own tissues. So instead of the immune system being the guardian against infections and any kind of foreigners that are invading the body, in this case, it's kind of like a friendly fire, if you will. The immune system directs its attack against the tissues of the body, and thereby causing damage and the symptoms that we see. So that's the definition of autoimmune disease. We don't find any kind of infectious agents, any kind of infections when we look under the microscope, but we do see a lot of inflammation as if there was an infection. So it's kind of infection, but there is really no microbe to see. And so that's the case for NMO, and that's the case for MOGAD. And let's just talk a little bit about what it means to be a relapsing or relapsing remitting disorders, because those are big words and they're often kind of gets confused. So relapse means that there is inflammation, ongoing inflammation that causes symptoms. So the implication of the statement is like this, that the inflammation has usually a very typical time course, how it develops and how it unfolds. It typically doesn't happen in a second, in a minute. It typically kind of unfolds over time. And usually it takes days or weeks for it to reach its maximum and cause the maximum kind of damage. And then usually it subsides. So the symptoms typically get better. So if you see this time course, when the doctor examines the patient, it's very important to get not just what hurts and where and what are the symptoms, but the time course. When did the symptoms come along? When did the symptoms come on? How long they lasted, and what happened to them later. In other conditions, let's say if you think about a stroke or heart attack, those are what we call them vascular diseases, when one of the blood vessels get clogged up and there is not enough supply of blood to an area of the brain or the heart, the symptoms evolve much faster. Typically minutes to hours, you're already beginning to see a lot of damage. In autoimmune diseases, the symptoms unfold over the course of days and weeks until they slowly kind of subside. And so that's the relapsing part, and the remission means that in between the relapses, in between the time when there is inflammation, there is quiescence, there is quiet. Not much is happening, at least on the surface. There is not much activity, there is not much symptoms. That's a relapsing, remitting diseases. They come and go. They have those episodes of inflammation, the inflammation subsides, and people feel better. Now, in between the relapses, people can still have symptoms. And in fact, as a rule, they do. Because unfortunately, the recovery from relapses is usually not 100%. It's the nervous system is such a delicate system, and there's so many millions of, let's say, nerve fibers going through the optic nerves and spinal cord, that any kind of damage, they're not 100% recovered. And usually people are left with some kind of residual symptoms, depending on which part of the central nervous system was involved. So if the optic nerves are involved, the vision may not be perfect. They may not have perfect binocular vision. They might see colors a little different from one eye to another, even in kind of mild cases. They might not be able to, drive very well at night because their night vision is not so good. In more severe cases, of course, they can lose vision in one eye and rarely in both sides. So depending on what part of the central nervous system is affected during attack, that will determine the residual relapses. And we're going to talk about that a little bit. As a rule, those symptoms that people have in between the attack do not stay constant from day to day. This is something kind of difficult for people to wrap their heads around. Why would it be that, the symptoms sometimes would get worse and sometimes would get better? But as a rule, the symptoms vary. If you talk to patients with MS and to some extent with other neurologic diseases, they all often, when you ask them how they're doing, they'll tell you, I have good days and I have bad days. That's a common answer to those questions. And it may depend on many different factors. It may depend on how well a person slept through the night, whether they are well hydrated, right? Whether they're overheated, whether they're under a lot of stress, whether, their boss yelled at them. All those things kind of factor in, and kind of body's ability to cope with those symptoms will vary depending on all the circumstances. A very classic example when symptoms seem to come back as if a person has another attack and another relapse is an infection, in particular either respiratory or urinary infection. As the body temperature goes up, as a rule, the conduction in the nerves decreases, and people develop more symptoms. This is a very common report in patients with neurologic diseases. And in fact, one of the earliest tests for multiple sclerosis, which is a related disease, that's way before the MRIs or anything else in the 19th century, they would actually ask a patient to take a hot bath, and they would check their vision before and after to see if the vision was affected by increasing the body temperature. So, this is one thing that people with those diseases kind of have to experience to get to know when they're having a true attack or relapse, or when they're having worsening of symptoms just because they're under stress or not feeling well or what have you. Those are called pseudo exacerbations. I don't like very much this term because it makes it sound that people kind of make it up. It's pseudo, it's not real. It's very real. It feels just like any other symptom, but the cause of it is not inflammation. There's not new inflammation in the brain and spinal cord. The cause of it is, if you will, kind of unmasking of the old symptoms. The old symptoms. I tell people it's like having if you're on a rocky beach, when the tide comes up, the rocks are covered up, and when the tide goes down, the rocks can be seen again. It's not a new rock every time the tide goes down. It's the same old rock. Sometimes you see it, sometimes you don't see it. So that's the situation with neurologic symptoms that are residual, that are left over from the relapse. So we talked about relapses, we talked about pseudo-relapses, exacerbation. Hopefully I kind of touch on some of the questions that people have, because this is what I kind of talk about to my patients, and I figure it might be of interest to this audience anyway, as well. So let's talk a little bit about now inflammation and how our understanding of inflammation really remarkably transformed NMO in particular, and soon probably will transform the MOG disease in terms of treatment. It is really, from the time that when I was a resident, when I saw my first patient who came in, to the present time, it's like night and day. It's a completely different world out there. At that time, we had no treatments for NMO. There was one series of 7 patients that were treated with a medication called thiopurine, which is not a very strong medication, occasionally still used, especially in resource-poor countries. And that was it. There was really no other treatments out there. Now we have 3 approved drugs for NMO. So how did we get there? How did we get from this desperate situation where people would accumulate relapses and disability, and we didn't know how to control them, to a situation where we have 3 approved drugs? So the breakthrough moment, no doubt, came when this Mayo group discovered the antibody that was a marker of NMO. We're going to talk to MOG a little bit later, but let's just focus on the NMO now because it's a little better understood. Not only did they discover this antibody, which is made by the immune system, which doesn't belong, a normal person really shouldn't have this antibody, they discovered what is this antibody directed against. And was directed against the water channel located on certain kinds of cells found in the brain called, mostly they're called astrocytes. Astrocytes is this kind of a supporting cell. It supports the nerve inside the brain. Astrocytes are not found outside of the central nervous system, which might explain why NMO is a disease of the central nervous system. And these water channels, the antibodies stick to the water channel called aquaporin 4 and initiates an inflammatory attack. So now it's understood fairly well. So once you understand what is causing the attack, and we understand who the players involved, we can start talking about what kind of treatment approaches we can have to prevent attacks from coming. What are the preventative treatments, the treatments to stop more attacks? And the first idea that was bandied about, which ended up being an extremely successful idea, was why don't we knock out the B cells that make this antibody, that triggers this inflammatory response? Why don't we knock them out? And we do have medications to do that, and the medication at that time that was used very much and still used now, a very good medicine called Rituximab, initially developed for treatment of cancers that are kind of, if you want to call them B-cell cancer. So this was a special treatment to knock out the B cells. Originally, those were bad cancer cells. But very soon, people realized that this treatment was very effective for many autoimmune diseases because B cells kind of play a part in them, a very important part. And very carefully at first, they started kind of experimenting with medication, see if it's going to help with the autoimmune diseases. So now it's a much more popular drug, I would say, in rheumatology, autoimmune diseases, than even in oncology. But in both fields, they are used very much, and there are probably more than 500,000 people treated with them. It's one of the most popular drugs. So this, maybe about 15 years ago, the first article appeared that, we had some patients in a series. I think it was an article out of UCSF in San Francisco at the time, and these patients were, having attacks even though they were treated, some of them with azathioprine, some other drugs, and we put them on rituximab, and 6 out of 7, I believe that was the answer, 5 out of 7, didn't have any attacks for a long period of time. So it looked very, very promising. And I remember reading this article, and I remember the first patient, who is still my patient here, I just saw her a couple of weeks ago, the first patient who had 3 hospitalizations that year, who I said, you know what, let's try you on this new drug and see how it will go. And in fact, she was remarkably benefited from it. So that's one of the treatments we have, the rituximab. Now we have other drugs that are kind of similar to it. And the one drug that was actually approved for NMO is called, it has a little bit of a difficult name, it's called Uplizna, I hope I'm pronouncing it correct. And it's directed also against B cell, but even a little more of B cells than the rituximab. So it knocks out an even larger kind of class of B cells than the rituximab. And just like the rituximab was shown to be very effective in stopping relapses, and based on the very rigorous studies that were conducted, this is now one of the 3 drugs that's approved for NMO. So that's one approach. Another very interesting approach is to look at what are the chemicals that kind of keep those B cells alive and allow them to secrete to make this antibody. And one of the chemicals that's needed to maintain the plasma cells, the B cells, is called IL-6. So the idea is, why don't we try to turn off this IL-6, turn off this signaling pathway, and it should help with some of the autoimmune diseases as well. And that ended up being an extremely successful approach too. Initially, we'd used a medication called tacrolimus, and we still use it. It's an anti-IL-6 therapy approved for treatment of rheumatoid arthritis and giant cell arteritis. And now we have a special drug approved just for MS based on the same mechanism called Enspryng or sartolizumab. And again, it was underwent very rigorous testing and was shown to be highly effective in stopping attacks of NMO. And the last medicine I want to talk to you about is very interesting, a very powerful medicine. So it attacks kind of one of the downstream effects, one of the bottlenecks of inflammation. Inflammation, if you imagine, goes through different steps. And one of the later steps in this whole process is something called activation of complement. It doesn't really matter what exactly it is, but if you don't activate complement, it's very difficult for an NMO attack to proceed. And there is a way with the medication to turn off this complement activation, to stop it. And if you do that, then you essentially shut down all attacks of NMO. And the efficacy of this drug is very high. It's more than 90%, which is an incredible result. And all of this is made possible, through science and through better understanding of inflammation and what are the players and which players to kind of target. So these are the main drugs that are approved now for stopping attacks of NMO. In addition, there are some older drugs that people still use, and a lot of patients are taking those drugs and are quite stable, and there's no real need to necessarily switch them to other drugs if they're doing well. But in terms of the approved agents, those are the 3. We have a medication for the complement called Solaris, a medication for the IL-6 called Enspryng, and medication for the B cells, knocking out the B cells, called Uplizna. So this is a way to prevent relapses. In addition, I don't think I'm going to have time to talk about it, there are medications used to help with the symptoms. The symptoms of NMO include pain, which is a very, very important symptom, and a very common one, and very difficult to treat, in fact. Bladder dysfunction, sexual dysfunction, weakness, balance problems, vision problems. So for these different kind of symptoms, we have medications also, and oftentimes not just medications, but non-pharmacologic, non-medication approaches, such as physical therapy, which is very important for strengthening and recovering people after this. Give me just 1 second. Hello? Oh, sorry, I thought it was a caller. I had to pick up. This is So that this symptomatic medications do not prevent relapses, but they help people feel better. Symptomatic, just like taking Tylenol when you have a headache, is something that's not going to treat whatever problem is, but it's just going to help you feel better sooner. So that's the idea. And finally, since we talk about treatments, we should talk about treatments that are given during the actual attack. So when there is inflammation, when kind of things are hot, we need to cool things off quickly. And for that, the preventative medications are generally not going to be helpful because they're going to work down the line. We need something that works right here and now. And the main treatments for turning off the inflammation, doing so quickly, are two, and they're steroids. Methylprednisolone is the most common one, but it's not the only one, and plasmapheresis. Steroids are very easy kind of medications to get. They're very cheap. You can use them IV for a few days, or in fact you can. There are ways to take them by mouth in very high doses, so it'll be similar to the IV preparations. Plasmapheresis is a very powerful way to stop an attack of NMO, and perhaps MOG as well, but certainly for NMO we have a lot of evidence. It's a kind of a dialysis program. It's blood filtration. It's usually done in the hospital. It doesn't have to be. It can be done. I have a patient right now who is going to be undergoing an outpatient, but usually it's done in the hospital. People stay there for about a week, and they are hooked up to this machine, which is kind of like a dialysis machine, and it takes out a lot of the inflammation out of the blood, kind of blood clearing treatment. It's very effective. Those are the main two: the steroids, high doses of steroids, and plasmapheresis. Okay, I think I'm almost running out of time, and I just want to say a few words about this MOG antibody disease, even though it's a kind of a new kid on the block, and we haven't learned about it nearly as much as we have about NMO, but an extremely exciting and active area of research. Because the more specific we get our diagnosis, the more targeted we get our treatments for them, and the better patients do. So MOG stands for myelin oligodendrocyte protein. And so it's found only in the central nervous system again. If NMO is an attack against something found on astrocyte cell, in MOGAD it's an attack presumably on something found on oligodendrocyte, which remember is the cell that makes the myelin. So this is also an inflammatory disorder, even though right now we don't have an official code for it. So if I see quite a few patients coming in, especially newly diagnosed with MOG, antibody disease, but there's no code for it. I have to make up some kind of a disease. I can either say that they have NMO or they have optic neuritis and so forth. That's how new it is. We don't even have like an official way of diagnosing them. But the people who deal with it, they recognize diseases associated with MOG antibody as a separate entity. And I think soon we are going to see that being widely recognized and separated out from MS and from NMO, and requiring different treatment. It's a very interesting condition. It affects children, it affects adults. It affects children and adults usually a little differently. With children, there's a lot of inflammation in the brain. A syndrome which is called ADEM, acute disseminated encephalomyelitis. It's quite a mouthful if you ask me, but basically it means there's a lot of inflammation in different parts of the brain. In adults, it usually is either optic neuritis or spinal cord inflammation or myelitis. The very interesting and important question is that oftentimes people have just one attack, and to our knowledge, they don't have any subsequent attacks. They have one relapse. And it's very important to figure out who are the people who are going to have more relapses, because maybe they need treatment to prevent them relapses. And obviously people who are not going to have more relapses, they don't need treatment to prevent relapses because they're not going to have it anyway. So this is a very active area to understand. With the NMO, we expect patients, by and large, will have more attacks, and we need to treat them. So even one attack, you need to start treatment and soon to prevent more attacks. With MOGAD, it's not at all so clear that people who had one attack are going to have another attack. In part, it seems to depend on whether this antibody, called MOG antibody, remains in the blood for a long period of time. If the levels are high and it's in the blood for a long time, it's one situation. But oftentimes, the levels come down and become undetectable. So something happened, there was inflammation, the MOG antibody was involved, and it went away. Those patients tend not to have subsequent attacks. We tend not to treat them. But every case is individual, and there are nuances. I cannot tell you how each patient should be treated. And frankly, oftentimes we don't know, and we kind of argue among ourselves whether we should treat them or not treat them. We go by best evidence. So in terms of, okay, so I think I spoke for about half an hour, and I think we're going to start the question answers now. And in terms of the future, I'm just going to conclude with this. So we made tremendous progress. It's very hard to find another area of neurology where there was much more progress made than in the area of NMO. It's kind of an obscure disease that hardly anybody have heard of, because most doctors have never seen even a single patient with this disease. And now it's well recognized, it's much better recognized than before. We have a test for it, we have treatments for it, and majority of times I tell patients when they come in with new NMO, I think it's going to be a pretty medically boring situation. With new drugs, people don't have attacks. They don't need to come to the hospital. There's no kind of excitement. I think people are okay with being boring, not as people, but as patients. I think that's where you want to be. And the next challenge is to try to figure out even more targeted treatments. So how can we not kind of affect the immune system in a general way, but how can we affect it in a very specific way? And the best way probably would be to see if we can tolerize people to this antibody. So if you think of somebody who has allergy to peanuts, a very serious allergy to peanuts, in theory, it's possible with the help of an allergist to desensitize. So people do not react to peanuts. There's nothing wrong with the peanut. It's just the immune system thinks it's something very bad. So can we sensitize people to this aquaporin 4 antibody for not the allergen that from outside from the environment, but from something inside the body? It's called tolerization. And if you can teach the immune system, when you see this, don't get overexcited. There's nothing really wrong with that. Don't start up a fight here. If you can do them, when we can probably achieve a cure of the disease, we can turn them off, and we wouldn't need to worry about treating them down the line. For now, that's not possible. We don't have a cure, but we have prolonged remission for a great majority of patients who really don't have relapses. Once they're diagnosed and put on treatment, they remain quiet. So that remission is the next best thing to cure, but we're not quite there yet. So I think at this point I'm going to pause, and I'm going to turn it over to Sumaira, who's moderating it. And I can take questions, and maybe I didn't cover some of the areas, and we can cover them in question and answer series. So let me just see. So I don't know whether Sumaira, you'll have to help me out here, because I don't see any questions. I'm not so familiar with Facebook. Believe it or not, for the first time I logged onto it was just a few minutes ago. So maybe I'm missing something. Let me just give a quick call to Sumaira and see how I can handle your questions. Hi, Sumaira. So how are we going to do the questions? I don't quite see them here. Oh, okay. Yeah. I'm making progress here. Yeah, I see some people are on. Okay, yes, I see them. Okay, so I think I figured it out. I have some patients asking here. Okay, thanks. I think we're doing good. Okay, thanks. Okay. All right. So I'll take the first question that I have here, and some of those questions have to do with specific cases, and I have to warn you that I cannot really give you definitive advice without evaluating the patient in depth. But the first question concerns a 19-year-old lady who has a MOG antibody, and when they were doing the investigation, they found that a thymus, which is kind of a gland, a very important immune kind of organ that usually gets smaller as people grow up, and you don't really see it in adulthood. In her case, the thymus looks big, and there is a question of whether it needs surgery. Of course, it's a very delicate question. I cannot really answer it. But the reason why it's such an interesting question is because there are some autoimmune diseases, and one of them I mentioned to you early on, which is myasthenia, in which it's a common treatment to take out the thymus. The thymus is supposed to be playing a part in this. So there is a precedent. The question is whether the thymus should be taken out or not. And truthfully, I don't know. I don't know if anybody discussed this in context of MOG antibody disease, but I do know that it is an approved treatment for other diseases such as myasthenia. And the other question, of course, is based on the imaging. Usually, it's a CAT scan, or they do. Are they confident that this is just thymus that's big, or there may be kind of a small tumor there is hiding in there that would require biopsy to figure out? So there are a lot of details and nuances to this. It's a very interesting question you're asking about the thymus. I'm sorry I cannot give you a definitive answer. The second question that comes is whether it's possible to have MOG antibody and NMO antibody. Can you have two of them together? It's a great question. The answer is probably no. You can have one or the other. In theory, there's no reason why a person cannot have two diseases like that. But in practice, we don't see it. Either they have NMO antibody or they have the MOG antibody. There are some patients occasionally who seem to have both, but in those cases, we almost always find that the MOG antibody levels are very low. And when they're low, they're not so specific. It's much more specific when the levels are high. So in those patients, and I've seen a couple of them myself, the NMO antibody is usually quite high and MOG antibody levels is quite low. In which case, considering the clinical context, what exactly happened in the MRIs and all that, usually you can confidently say, hey, this patient has NMO. I don't think he has MOG. I don't want to be 100% definitive about it, but the current understanding is that you can have one or the other, but not both. The second question relates to switching from Rituximab to Troxima, which is a kind of a generic version of Rituximab. I don't have very much experience with Troxima, but I think the thing about Rituximab, remember how it works, and same thing for Troxima, it works by knocking out the B cells. So you can actually, it's one of those medications that you can actually figure out whether it's working or not by measuring the B cell concentration in the blood. And we routinely do them. And we want the B cells to be essentially absent, to be close to zero. That's how we know that the medicine really works optimally. So I think if you're switching from one to another, from maybe one generic to a different generic, I think it might be important to follow up on those B cells in the blood to see if they remain zero, because that's, at least in NMO, that's an important kind of marker of success. If you manage to completely eliminate them, the chance of relapses are much smaller than if you haven't completely eliminated them. So that's something that you follow in practice. Okay, another question. Okay, a relative of mine had MOG antibody and has been on a high dose of a medication called Celsip, which is an immunosuppressant, commonly used for transplant patients, but used in autoimmune diseases as well. Should they be tested routinely for MOG antibody? Great question. Those are all your questions are great questions. So it really depends on his history. If he had multiple attacks of inflammation, especially if the attacks were severe, involving the spinal cord, I think you have a very good argument to continue treatment, especially if he doesn't have any side effects from the Celsip. If he had only one attack and his MOG antibody titers went down, then you have to really sit down with your doctor and discuss whether it would be possible to maybe taper them up or not. And unfortunately, there's no one right answer. It really depends on a lot of factors. And it's not entirely clear, even if the titers are low, are they low because of Celsip or they would naturally come down? That's not entirely clear. But certainly if he has one attack and his titers are negative, you can start thinking about maybe, in some cases, tapering the medication, stopping them. What would you say is a simple description of MOG antibody-mediated disease to explain to friends and relatives who have no idea what we're talking about? So I think we've touched on it early on in the talk. I think you need to say it's an autoimmune disease. It's not an infectious disease. You cannot pass it on from one person to another. It's not a genetic disease as far as we know. It's not something you can pass on in the genes. It's a disease having to do with an abnormal functioning, hyperactivity of the immune system. In this case, the immune system directs its attack against the central nervous system, the brain, optic nerve, and the spinal cord. I don't know if this explanation is very clear. It's a disease that's relapsing, that kind of comes and goes. So I would kind of touch on some of those main concepts. And it's very variable how people do. Some people, most people with MOGAD, I would say, are not particularly disabled from the attacks, but unfortunately, we do occasionally see people who had multiple attacks, didn't recover well from it. But there are also a lot of people who have it, and you wouldn't know it from looking at them that they had it as well. So it's very variable. There's not one kind of mold for every patient. So maybe this will help you explain to your friends what it is. Okay, next question is a great question, another great question. We have a MOG antibody positive patient with multiple relapses, and in two cases they seem to be connected to the vaccine. One was the H1N1 vaccine, which is a strand of flu about 10 years ago, and another was the vaccine in 2013. Do you know anything about the two approved vaccines triggering relapses? So I think the question is about the COVID vaccines. So in theory, this is a very important question. In theory, vaccines stimulate the immune system, right? Just like the infection stimulates the immune system. When somebody is infected, the immune system has to be activated to fight and contain the infection. And to some extent, this is happening with vaccines as well. So vaccine can trigger relapses. The important thing to understand, especially about the flu vaccine, that the flu is actually more likely to trigger relapses than a flu vaccine. So I'm not talking about the individual cases. The gentleman or the person had 2 attacks following flu vaccine. I think prudence dictates that they probably should not get more flu vaccine. There's something unusual about their body responding to them. If truly there is a connection between the two, meaning to say the relapse occurred within usually a few weeks, but certainly not more than a few months after the vaccine. So this is more of an exceptional case. In most cases, the infection is a much bigger enemy than the vaccine. Now, the COVID-19 vaccine is a brand new area where we know relatively little. The patients with autoimmune diseases were allowed to participate in the trials, but they would not accept patients into the trials who are on any immunomodulating or immunosuppressive therapy. So if anybody is on Rituximab, anybody is on Celsep, they would not be allowed to participate in the COVID-19 trials. So we don't have a lot of actual experience with those trials. But I would, if you ask me to give me my guess, I would guess that the enemy here again is the infection, is the COVID-19, which unfortunately has caused such terrible damage in our country and many other countries of the world. I think the enemy will be the infection and not the vaccine. In the trial, there are 2 trials that are now publicly available to review the results, and they're reviewed by the FDA. You can find them online. It's about 50, 60 pages to review the reports. One is for Pfizer, another is for Moderna. They're both mRNA vaccines. There were no cases of, like the gentleman described, of autoimmune conditions being caused by the vaccine. So does it mean that there will never be cases? Probably not. But I would probably guess, based on what I know so far, that it would be very unlikely for the vaccine to cause an attack of MOGAD. But we have to see. This is just theory. In practice, I already have patients. Last week was my first patient with multiple sclerosis who works in the emergency room, who asked me whether she should get the vaccine, and I told her I believe that she should, because where we work in New York, we have a lot of COVID. A lot of them are coming in on the floors right now, and the chances of her getting it and suffering complications from it, in my view, outweigh the theoretical worries and concerns about getting the vaccine. So far, she just texted me on our record that she's doing fine. Do you know what trigger a MOG crisis? How common infections are recalled to be a trigger? This is a very important question, because if we knew what triggered them, maybe potentially we could avoid them. And until maybe a week or 2 ago, I would tell you that we have no way of knowing what goes on, what is the marker that a relapse is coming. And somebody just sent me an article was written by my colleagues at Harvard, Dr. Chitnis and others, and it looks like they may have discovered some markers that correlate with relapses. So you might be able to see some changes in the immune system as a relapse is about to take place. This is very, very early developments. And maybe if we have a marker, we can kind of go backwards and figure out what caused this particular marker to go up and, kind of unravel. Because one of the big mysteries in relapsing remitting disorders is why. Why would a person who hadn't had a relapse for 10 years all of a sudden have a relapse? Sometimes we can say, well, maybe he had a relapse because he had a very bad infection, he was in the hospital, but usually we cannot. There's nothing unusual about what's been going on leading up to the relapse compared to, let's say a few months before. So this is one of the mysteries of relapsing remitting diseases. Why do they come and go like that? What triggers them? What sets them off? Infections, rarely vaccines, could be triggered in few cases, but in most cases we really don't know what triggered them. Is it possible to have a relapse without MOG antibody found in the blood? So I presume you're talking about the MOG antibody-mediated disease. It's interesting. I haven't seen it myself. I mean, if the patients have MOG antibody during the relapse, I cannot think of a single time that they would not have antibody. And generally speaking, people who have antibody and then it disappears, they tend not to have relapses. To my knowledge, the answer to the question, is it possible to have a relapse without MOG antibody, is either no or very rare. But this is based on my experience. It's not very extensive. To give you an idea, we have about 200 patients with NMO and MOG that we treat in the NYU Center. So, probably about 70 or so of them right now have MOG antibody disease. How common are patients who are both aquaporin negative and MOG negative? Patients who have optic nerve and spinal cord lesions but are negative for both tests. So they are rare, but they are seen. We see them. Those we call them seronegative. They're serum blood. They're negative tests in blood. Seronegative patients. There's a handful that I can think of that have optic neuritis or myelitis, but they don't have any antibody associated with it. It's probable that we just haven't discovered enough, and maybe in a few years we'll have more markers. But majority of patients with autoimmune disease of the central nervous system fall under those three categories. Multiple sclerosis, by far the most common, almost 100 times more common than the other diseases. Neuromyelitis optica, and MOG antibody-associated disease. And then there is the cases that you mentioned where there is no antibody associated with it, just inflammation, we don't know why. It's a relatively small group, but it does happen. Next question, Dr. Chen published retrospective study finding IVIG as the most effective treatment for MOG. Case series having no relapse with inoculizumab. What has your experience has been with IVIG versus tocilizumab? Tocilizumab, you'll remember, is an anti-IL-6 monoclonal antibody that we use now fairly routinely for NMO. And I'm speaking from memory, but I think I only have 2 patients with MOG antibody on tocilizumab. It's not the first drug we think of. Maybe it should be, but it's not. And I'm aware that there are a number of case reports in the literature showing that it may be quite effective in treatment of MOG antibody disease. IVIG, intravenous immunoglobulins, is usually monthly infusions of immunoglobulins that are pulled from thousands of different people. And it may have various effects on the immune system. And it's used for various autoimmune diseases. For example, Guillain-Barré, it's an approved treatment for Menger, but it's used for many autoimmune diseases as well. IVIG is a very expensive drug, and many other drugs are also very expensive, by the way, so it's not unique in that. And the very nice thing about it is it doesn't suppress the immune system. Especially now, during the COVID pandemic, we think about safe treatments for, MOG antibody, and this that definitely stands out as being some treatment that doesn't suppress the immune system. And it is probably not effective or not very effective for NMO. That has been kind of the consensus of experts, but I don't know if there are any formal studies done. So, IVIG, I think, over the first-line treatment for MOG antibody disease, and tocilizumab, I think of being a second line if something doesn't quite work. But we may reassess, and in a few months we may maybe would say something different. Because in NMO, we have very good, high level, very rigorous trials. But in MOG antibody disease, we don't have any kind of randomized, placebo-controlled or trials comparing different drugs. So the evidence is much weaker for MOG than for NMO, and it's not surprising because MOG is only a few years old, at this point. We just started testing for it, literally 4 or 5 years ago. Can Rituximab impact MOG titers? The answer is probably yes. Especially with chronic use. A lot of times we see not just the titers to specific antibodies, but immunoglobulins itself tend to go down with time. So I think that can happen. What is the true rate of MOG monophasic disease in percentages, and how long is the longest study to decide if you can really say cases can be monophasic? Okay, let me see. I might have some articles on that. So this one was a recent review that I was reading not long ago. And I'll give you the reference here. If you want, it's freely available. It's called Recent Developments in MOG IgG-Associated Neurologic Disorders. Recent Developments in MOG IgG-Associated Neurologic Disorders. And it's freely available. So let's see if it has an answer to your question. How many are monophasic and how many of them are polyphasic? Okay, so this here it quotes a few series of how many of them have persistent MOG antibodies. So the numbers range from 36% to 90%. On average, it's about 50-60% seem to have MOG antibody titers that remain elevated. And let's see how many are monophasic. Does he give that number here? No, I don't see it on the... My sense of it as monophasic is much more common in children, where I think it's estimated about 80% of people who have, let's say, ADEM and MOG antibody, their titers tend to go down, and my colleagues who treat kids almost never treat them after a single event because overwhelmingly the titers go down. In adults, it's not as common for the titers to go down. But I don't know if I have, my experience is about 50-50. But I don't know if I have a better number for you. It's got to be. So in that reference I gave you, I think they will provide you more. Professor, okay. Lymph node showing cellular changes. So there's a note from Professor Irani on marker of the lymph node showing cellular changes. So I'm going to take down this reference, Dr. Irani from Oxford. I have to look it up because I'm not familiar with that study. It's a very rapid field. It's hard to keep track. And I'll follow up. So thank you for that comment. And we are fundraising to fund the research belief you can predict after relapse. Well, that would be a tremendous contribution to the field, and kudos to you for supporting this important work. I was under the impression that the MOG antibody mostly affects the optic nerve. What are the signs when it affects the spinal cord? Okay, so the spinal cord is a cable that's about as thick as a thumb. Thick on the thumb, and it connects the brain to the body. That is really the main, in many ways, the only connection between the brain and the body. So, in order for the body to move, it doesn't just do it on its own. It has to receive the command from the brain. So, if the cable that connects the brain to the body is impaired, one of the most important and most disabling symptoms is that the body doesn't move, or doesn't move as well as it should. The signal starts in the brain, it goes and kind of gets intercepted and kind of lost or degraded at the level of the spinal cord. And then by the time it gets to, let's say, the arm, or more commonly the leg, the nervous signal is too weak to kind of move the leg. So the common symptom of spinal cord disease is weakness, usually in the leg, but can be in the arms as well. Another common symptom is loss of sensation. In this case, the signal from the legs doesn't quite get into the brain, and oftentimes that not only there is a loss of sensation, but the brain, because it doesn't receive accurate information, actually misinterprets the information, and they're almost kind of body illusions that people have. They might feel like their body, their leg is swollen, or it's cold, or there is something crawling inside it, or tingling, or itching, or hot, or burning. Those are all kind of illusions of pain, not because there's anything wrong with that part of the body, there really is not, but because the brain perceives it, the signal, and the signal is distorted. So it's kind of the brain is getting the wrong intelligence. And very commonly, in addition to motor and sensory symptoms, is what we call autonomic symptoms. Those are bowel and bladder control, especially the bladder control, is very, very commonly affected in MOG antibody disease, which tends to affect the bottom of the spinal cord called the conus. And it's very common for people to have increased urination and getting up at night a lot or being difficulty controlling it, as well as sexual function, which kind of goes closely with the bladder function. So yes, so to answer your question, it doesn't just affect the optic nerves, it can definitely affect the spinal cord as well, and it can affect the brain. And do you know if sertolizumab clinical trials reported 4 included MOG patient, and if so, the effectiveness of sertolizumab in MOG antibody group? I don't think that this data has been presented. You know, I think there were patients who were aquaporin 4 antibody negative in the trial. To my memory, I have to look it up. And in theory, it would be possible to test all those patients to see how many of them have MOG antibody. But to my knowledge, this data has never been presented. It's a great question. It will be very interesting to see. Okay, when current expected clinical trials for MOG antibody therapies. I'm not aware of kind of something that's publicly available. I know they talked about certain immunoglobulin treatments for MOG antibody, but I'm not aware if something is publicly available. A good place to find out is to log on to the site called clinicaltrials.gov, clinicaltrials.gov, one word. And there you can type in the name of the disease, like MOG or NMO, and you can see any of the active trials, because all the trials are required to be registered on this website. Okay, and Sumaira Foundation, it's time for one more question. Okay, well, you don't have to ask one more question, only if you want to. But I think we covered a lot of ground today, and I thank you for your participation. A lot of very sophisticated questions, I would say. Okay, can you say more about MOG antibody and urinary dysfunction? As we said, this is a very common problem in those who had spinal cord attacks. And are there treatments that help recovery? Well, the treatment that help recovery are the same treatment that help recovery for relapses. Usually it's steroids or plasmapheresis. Some people occasionally use IVIG. But even people who have excellent recovery, who have good walking skills, no dexterity problems, often do notice that their bladder function has changed. And then those symptoms are treated symptomatically. So oftentimes the issue is that there's a lot of kind of spasticity in the bladder, and people have urgency, and they feel like they just emptied out, and they feel like they need to go right away. And there are medications designed to relax either the sphincter or the bladder itself, and they can be quite effective. Another treatment in more severe cases is Botox injection, not for wrinkles, not for beauty, but Botox injection into the bladder itself, and the Botox kind of paralyzes the muscle, relaxes the muscle, and oftentimes it's very helpful because it stops some of those cramps. And there are some more sophisticated treatments as well. I think we're getting better at treating bladder problems, but we're still far from perfect. And there are urologists who specialize in neurologic diseases. If they have such specialists, they're called neurourologists in your area, it might be helpful to consult with them. And I think we're running out of time, and I thank you very much for your attention. It was a pleasure to be here, and I want to say kudos to the Sumaira Foundation for organizing it. I hope this was somewhat helpful to you. Thank you very much, and happy holidays to everybody.